Thank you, Dr. Shang, for the kind introduction. Let me share my slides now, then I will walk through the slides together with you. So, I'll be presenting most of my work today on advancing automation in healthcare through multimodal reasoning. So the topic that was earlier shared by Dr. Zhang is still relevant, but I just felt that in addition to how we use multimodal reasoning in surgical assistance and automation, I wanted to thought that expanding it to general healthcare may actually give a broader vision of what we are currently doing or what's my current research topic about. And just to give a early understanding of the research and the topic itself, while the current talk primarily focuses on multimodal imaging and precision care, my topic will be more focused towards how we are leveraging multimodal data and multimodal reasoning to improve the clinical care delivery. For example, how we take care of patients and how the patient outcome can be improved through improving precision and improving the introducing robots in that sense. So not more from a medical imaging perspective, but more towards how we do a care delivery perspective. So in that sense, let me give a brief introduction of why there is a motivation of my current research first. So my research currently focuses on addressing the pressure points in healthcare system in general. So healthcare around the world is facing mounting challenges, including US, China, Singapore, and anywhere around the world. These are primarily due to rising workforce shortages. Basically, there is a lack of physicians around the world, and as the clinical care demand increases, we are unable to sustain the demand with purely our supplementing the workflows alone. And as science and medicine progresses, there's also increasingly complex care delivery. How we care and how we provide clinical care is getting increasingly complex. So this actually increases the stress point in the healthcare because we have to now, in addition to training new surgeons, new clinicians, we have to update the knowledge of the current clinicians as well. And there is also a rising patient volume. This is primarily felt, this is largely felt in Asia, where there's a very high rise in aging population, particularly in Singapore and I believe parts of mainland China as well. But this is surprisingly quite a significant trend in US as well. So it is felt that by 2034, adults who are more than 65 years of age is going to outnumber the younger generation. So there is also a expected rise in patient volume. So how do we tackle this how do we tackle this need? So the very fact that we cannot tackle this by brute force method, basically, if I have a demand for a physician, can I just increase the number of physicians to care for the patient? Can this be done? Well, not exactly, because first of all, is every time you need to train a clinician or a surgeon, there's always a lead time. In US alone, training a surgeon or a specialized surgeon, it takes about 12 years in training. And if you want to expand this problem, not just taking into consideration of the time alone, there's also a chicken and egg problem. Means if you want to train more surgeons or more clinicians, you need more expert clinicians. And for you to have more expert clinicians, you need more students in the first place. So it's a chicken and egg problem. So who comes first? And also, it is not reasonably viable for us to fully replace clinical care by robotic solution or automation solution. That's purely because a clinical care is a very complex domain. And as much as we see robots and intelligent system being able to do more autonomous things, when it comes to clinical care, you require that clinicians' understanding of the diagnosis and clinicians' ability to care for patient, and they just bring a holistic situational awareness and a better bedside manners and ethical reasoning. And in any problem situation, robots are trained to perform a task on a known scenario, but humans are able to, adapt to a evolving situation and do a more judgmental call. So taking this into consideration, my research primarily focuses on how we can introduce assistive and automative technologies as a force multiplier. So we don't try to replace a clinician, but how can we enable them, not just from a clinical care delivery perspective, but also in training them to say that, okay, now one surgeon or one expert clinician can actually train 20 students better, or one clinician can perform a surgery even better and faster compared to the past. So this is a way of how we try to address the need in the healthcare system. And to emphasize the fact that we are not trying to replace a clinician, but rather we try to see establish a symbiotic relationship between a clinician and an intelligent system. So how can we bring humans and intelligent machines together to actually give a more improved clinical care delivery? So this summarizes my research overview or my research progress itself. So my research focuses on driving the future of automation in healthcare to transformative assistive and automation technologies. In that sense, I primarily focus on three synergistic automation domains, which is automation in clinical education, and surgical assistance and automation, and clinical workflow analysis, which is ambient intelligence. For this talk, I will primarily focus on clinical education and surgical assistance and automation. For automation in healthcare, why do we need multimodal reasoning is because humans, there's a saying that a picture speaks a million words. That also means that we can interpret a surgical scene, and what we can learn from the surgical scene also differs a lot. But for us to actually understand it better, we actually need to translate it to human readable senses, which is language. So as much as there is an image, if you want to interact with an intelligent system to actually talk about, let's say I want to learn a surgery, I have to interact with an intelligent system or an expert to say that, okay, this is a surgical video, this is happening, so what's happening now and why this instrument is used. So this is why we try to do a multimodal reasoning, which is basically we try to align a language context with the image context. So this is one of our earlier version we developed for interactive learning assistant for robotic surgery, where you can just upload a surgical video and you can ask a question. So when a surgical scene is given and a question is asked, the multimodal reasoning model predicts keyword answers, which are then prompted to language descriptive models or large language models to actually give a more grounded description of the scene and the answer that is more aligned to the question itself. And while this enables one of the application here, which is interactive learning assistant, the primary building blocks is actually a multimodal reasoning model, which are actually a vision language model. So prior works include developing two multimodal models, which is basically a surgical VQA model, which we developed in 2022. It was a bidirectional model where, in addition to the surgical scene itself with robotic instrument action, we try to ask questions about what is the state of the instrument or what is the phase of the surgery and everything. So these models are then, these input data are actually then fed into a multimodal transformer models that actually does a bidirectional encoding. Basically, it attends to all the question words and it attends to the whole surgical scene. Then it tries to predict an answer here. Then this was further expanded to a GPT-based model in 2023 because we wanted not just a single word or a sentence level answer, but we wanted this model to expand we wanted to introduce the capability for these models to expand to a very big paragraph-based answer. So given the recent progress, or back then the recent progress in GPT-based models for large paragraph-based results or answers, we expanded this surgical GPT model where, in addition to surgical scene, and in addition to question, you're able to have a more descriptive answer, like not just a single word answer, but it can give a sentence level, or over time, you can also train it to give a paragraph level answer. So these are multimodal reasonings we have been trying to do. And the key difference between these two models from an architecture perspective is for a surgical VQA model, we actually used a visual BERT model, which is more like a bidirectional model. So it sees the whole question and it sees the whole vision data and it predicts a single word answer or it predicts a whole sentence. But it's limited by what's the maximum output word it can provide. But the good thing about surgical GPT model is an auto-regressive model where you give a vision data or you sequence the vision data and a question data, and the output can actually be expanded over like multiple sentences because it generates one word at a time, so in an autoregressive way. So this is where we try to leverage these autoregressive models for more descriptive answers. Then we wanted to expand further further expand multimodal reasoning for clinical training. So this is where one of our works involve how can we use explainable AI to actually further improve surgical skill acquisition. So in the past or even in the current trend, the clinical students, they either learn how to do suturing in their classrooms with experts standing beside them and teaching them how to do. Or sometimes when experts are always not available, they actually go back to surgical videos and they actually see how a surgery is done or how a skill is done, and they try to mimic that action. But the problem here is when they try to do a self-guided learning, they don't explicitly know where they are making mistake unless they are trained to look for those mistakes. So I can follow a surgery, but I wouldn't know how much my hand should turn or how much my hand is turning or inserting a needle compared to an expert. So this is where we try to leverage an AI model, multiple AI models in parallel to see, can we then use explainable AI models to say, okay, this is the expert way of performing a surgical suturing, and this is your way of suturing, and these are the specific differences that exist between how you needle or how you insert the needle or how you tie a knot versus an expert, and can you then improve? So this is actually a study we did last year. And to enable this study, we actually leverage multiple AI models at the background. For instance, when a student or a med student is actually performing a suturing task, we actually take the vision data, but vision data is actually processed into multiple different modalities. So in one sense, we're actually doing a hand tracking. So we try to track the hand, and we try to track the fingers. And the second one is we try to track the tool position, like what's the orientation of the tool, what's the trajectory of the tool. And then we also try to predict the gesture recognition. So this is a video-based recognition where throughout the whole suturing task, we break the surgical suturing task into multiple phases or gestures where we pick up the needle, we insert the needle, we lay a knot, we pull the thread. So we break a surgical task into multiple phases, and together with this broken down phases, we actually combine it with hand tracking and tool tracking to create a what we call is a proxy gesture pair. For example, a proxy gesture can be what's my distance between my thumb and an index when I'm actually cutting the suture, or what is my hand orientation when I'm inserting a knot. So these are considered how's my hand and dexterity of my hand together with the tool compared to a surgical face gesture itself. And when these are actually primarily evaluated, then we compare the metrics or we compare the key parameters of these tracked items in comparison to the gestures against the experts. And we say that, okay, this is your action and this is the expert action. This is where you need to improve. And we actually found few changes where this was a control study or limited control study where the participants were about 15. And now we are expanding the study to an even bigger pool. But even in this sample size, we did see that participants were able to better understand where they had to improve, and they started making changes to their surgical tasks. So this is one instance where we try to introduce multimodal reasoning to actually improve improve the skill level and skill acquisition of the surgeon, so that we can provide a better care delivery to the patients. And the next topic I would be talking about is surgical assistance and automation. And in terms of surgical assistance and automation, my research primarily involved multimodal surgical scene understanding and surgical automation. What is scene understanding? It's basically how humans sees any scene and how we reason on it. So for any robot to actually automate in a more explainable and more safer way, it must first understand what's happening in the scene. If the robot doesn't know the suturing is already done, we wouldn't know that it does now have to cut the suture end, right? So this is where we try to enable intelligence to the robot. And this, for instance, we actually introduce multimodal reasoning. So the first work, one of the first work I did is basically globally reasoned multitask model for surgical scene understanding, where contemporary convolution layers, they primarily focus on like a grid of patches where they try to reason on the scene, but they lack global reasoning of the holistic image itself. So we try to combine both the reasoning, where in addition to leveraging multi-level local reasoning of the patches, we try to have a holistic understanding of the image here through a latent graph representation to extract the features. Then we then use it to improve the instrument segmentation to understand where the instruments are within the scene, and to also understand what is the interaction of the instrument with the scene or the tissue itself. So this we present it in a surgical scene graph where it represents different instruments and its interaction with the tissues. For example, here the grasper or the cauterizer is actually cutting the tissue. Here the suction is doing a suction on the tissue surfaces. So this is how we represent the graph. So in this sense, we actually built a multitask model where the model is able to perform both segmentation and scene graph inference purely from image and also word embeddings. Here we introduce, in addition to the vision system, which is basically an endoscopic view of the model, we also introduce word level embedding so that we can improve the performance of the tool tissue interaction detection, so that over time, this work can be expanded to vision language models. In that sense, that this can be directly then used by the models you have seen prior, such as the surgical GPT model, can then leverage these data to actually have a more descriptive explaining of the scene, or also to plan a surgical event. The next work actually involves automation of a surgical task. In this sense, it primarily shows a pick and place of item using a Da Vinci system. While this is directly not a surgical scene, but this is primarily how we train clinicians in terms of dexterity as a first step. Here, what you see is, while you see the robot is moving and it's moving in a based on a RGB scene, the robot's control is primarily done at a very high level or a very different paradigm, which we call it a digital twin based control. So when we leverage not just the RGB image alone, but we also introduce depth data. So what we here try to do is we see the scene as the camera sees, but this scene is then expanded or is then lifted to a digital representation where we see it from a more digital scene perspective. So we see the depth of the object, we see the object itself, and we see the classes. These are primarily enabled by foundation posts and foundation models for segmentation. Why do we do this? Is every surgical scene over time will differ depending on the patient itself. There's going to be always a domain shift. But we don't want our automation system to fall onto this problem of domain gap or out of domain distribution. We want the robotic solution or the surgical automation solution to be robust to changes in surgical scene, how the tissue differs or tissue surface differs. And can we then leverage these models to say that, okay, irrespective of how the scene is, if I'm able to extract this scene to a digital representation, all I have to then do is build a robust robotic solution that can only see this digital scene and automate the solution. So moving forward, I don't have to worry about how do I have to improve the robot actuation or control for every different change in patient, but I only have to worry about how can I link any and all patient distribution to this digital twin. And as long as I achieve this, my robotic control between digital twin and the patient care itself can be guaranteed. So this is where we try to introduce a more robust and flexible solution that is primarily guided by a digital twin paradigm enabled by foundation models on multimodal data input. So with this, I believe I conclude my presentation. I'm open for questions and answers.